Question to Dr. Loomba is, I have been following some fatty liver patients for over a long period of time, and I see uniquely some patients will transition from just fatty liver to cirrhosis to even HCC fairly rapidly. On the other hand, there are some who are lingering forever. Is there a genotypic differences? Can we predict who's going to transition, who's not?
So people are trying to develop genetic risk scores by pulling in PNPLA3, MBOT7, TM6SF2, and seeing if that would, provide you, say, a 10% or 15% risk of progression. But currently, those data are not available. I think they'll be coming out in studies such as either our familial cirrhosis or studies where you enrich phenotypically based upon the risk factors first, and then add genetic approaches. I think the easiest thing would be a 50-year-old type 2 diabetic with metabolic syndrome, and potentially in those looking at genetic risk on top of it, because you already have an environment, because NAFLD and NASH progression is a gene-environment interaction, in my opinion. You may be able to identify those that are likely to progress. There's some data on ELF, where they took patients with bridging fibrosis, and those who had ELF greater than 9.8 had a higher risk of progression to cirrhosis. Among patients with cirrhosis, so you may have 100 patients with NAFLD cirrhosis, who is going to develop hepatic decompensation, you could potentially use ELF there as well. Same idea, you could use elastography also in those patients and look for outcomes.
Thank you. In HBV DNA suppressed patients for follow-up, should we be monitoring the BSAG titer or just sporadically, how often, surface antigen, period? And the other question is, if you're lucky enough to get a surface antigen loss, should we be following up with a B vaccine to try to boost the surface antibody?
Yeah, those are terrific questions. I didn't really speak to the surface antigen quantitation, so it is kind of the new tool we have. There is some data that suggests that among patients that are e antigen negative and are suppressed, that if their surface antigen quantitation is less than 1,000, less than 100, it depends on the study, that may be the group in which we would think about doing withdrawal of therapy. So if you're enthusiastic about considering withdrawal of therapy, then I think surface antigen quantitation can help. I think it's not perfect, but it's another tool. So if I have a patient who's very eager to come off treatment, I use the surface antigen to help guide that discussion. If it comes back and it's still 12,000, I tell them that it's very unlikely that the withdrawal is going to lead to sustained remission, and that maybe they'd be best to stay on treatment, for example. So I think it's useful in a sort of select way. And then, here's your question.
Yeah, there was to vaccinate,
vaccinate,
if you do
no.
lose surface antigen. Any data, or
there's
intuition?
There's actually a lot of, the HBRN network is actually, we just finished looking at this data. So the presence of surface antibody doesn't influence the stability of surface antigen loss. And so that means that if somebody loses surface antigen, you don't need to wait or try to induce the antibody, because it'll eventually come, and they don't have a higher risk of reactivating or seroreversion if they don't make the antibody. So I don't see a role for vaccination.
Okay, Fred?
I have two questions about NAFL. Using vitamin E, there seems to be so many mixed signals. You're not supposed to give it to diabetics because of the risk of hemorrhagic stroke, and you didn't mention that. And whether you use the 800, because it was the old study saying increased cardiovascular mortality, which was subsequently poo-pooed. Some of us hedge our bets and give half the dose. Some people say just don't give vitamin E to diabetics, and forgetting the prostate risk. So, and the other question is, why isn't brewed coffee up there as a treatment every lecture? Because you get kind of cynical, because there's no drug company that studies it, but data keeps coming out that it's great, 40% decreased liver mortality.
Yeah, I think, the reason we say the vitamin E is not in diabetics is because PIVEN's trial didn't include patients with type 2 diabetes. But I'll give you another example. In the Flint trial, which is obeticholic acid versus placebo, we let patients in if they were on vitamin E. And they were randomized if they were on a stable dose for 90 days, either to treatment or placebo. So we looked into those who were diabetic but got vitamin E within the Flint trial. 56% were type 2 diabetic, and it still worked in those patients. But the idea is that if you don't do anything about the type 2 diabetes, because vitamin E is de-linked with insulin resistance, it doesn't do anything to it, that you may not be solving all the problems that the patient may have. It's more likely to work in someone who hasn't developed diabetes yet, because mechanistically, although they still have insulin resistance, would be less of a problem driving steatohepatitis progression.
So it's not because it's a risk factor if you're
No.
diabetic and stroke?
No, I think majority of the stroke that you would see in a diabetic, in my opinion, is going to be ischemic stroke. So the key thing for us to see is that when you're prescribing it, that they shouldn't have uncontrolled hypertension. And I think if you focus on that, then I think it might be reasonable. Overall, it's still pretty safe drug than some of the new drugs we are developing. We just don't even know about them. Within the NASH CRN, there is a movement to try to test out a lower doses of vitamin E to see if that might also be useful. But I feel comfortable, say, if I have a patient who doesn't have uncontrolled hypertension, I don't expect them to have a high risk, especially in women without hypertension. I use vitamin E a lot without any problems, 800 units, and I monitor them. The other thing you could do also is you could treat them for a year or two, and suppose they started with an ALT of, say, 65 or 70, and the ALT went down to below 30. Jay Hoofnagel and a few of us wrote a paper that Jay led where we just came up with an ALT response, because nobody wants to repeat a biopsy to show if the patient is improving. And those patients whose ALT went down by 30% or below 30, those had improvement in their liver histology also on vitamin E. So you can use that as a treatment response indicator.
Coffee?
Coffee, I think coffee is going to be a great leveler. I think it's, to me personally, I think it's not the coffee, but the person drinking the coffee and the phenotype of that person. More drinks being beneficial. I don't think that it's going to be potentially used as a treatment per se. It potentially could be protective. But when I started studying epidemiology, the first paper they showed us was coffee drinking preventive for pancreatic cancer. And
No, caused it, and then it was rebuffed.
And then protective later on. So I think many of these associations say red wine use and protection for liver disease, followed by coffee use. It may be the people drinking those and their lifestyle and how they are potentially impacting their disease status.
Yeah, but what decreases 40% all liver mortality? Nothing does except coffee. Finally, statin is not a treatment for fatty liver, but the effect is so much more pronounced on people with fatty liver as far as cardiovascular death. That should be in the algorithm too.
So I think the statin is a real thing. Coffee, I think, is more where it's the type of people drinking coffee. Statin would lead to reduction in CVD mortality, and I think that would be beneficial. 80% of my patients are on a statin, and the question that I ask is, why somebody is not on a statin rather than they shouldn't be placed on a statin just because they had an elevated ALT.
Okay, Paul?
So a couple of questions, all related. Given the cohort of patients coming in with Hep C and these IV drug users, if they're still using drugs, would you treat them? If you do, and they get reinfected, would you treat them again? If you don't treat these patients, where in their rehab would you say it's safe to treat?
Yeah, that's a great question. There's no way that we're going to be able to eliminate hepatitis C unless we treat within that population, because that's where all the new infections occur. So if we want to get our new infections to, the 95% reduction, we're going to need to do it. And there's very good data that shows that if you treat individuals who have recent drug use, ongoing drug use during HCV treatment, that their response rates are the same as somebody who's not treated. So there's not a reason not to treat. Do they get reinfected? Yes. And there's actually, one of my favorite quotes about that is, if you don't see reinfection, then you're not treating the right patients. If you're really trying to get into this group of patients that has very high risk for transmission, the data suggests that maybe it's somewhere between 5 to 10% at sort of a 3 to 5 year period. And yes, you're going to need to retreat. And the data suggests that, they do change their behaviors. It's very interesting that the success of being treated for Hep C actually sometimes has beneficial effects in terms of other parts of their life. They tended to decrease drug use. They often are more open to considering, MAT or other programs. So I really feel like this is where we want to go. It takes a special team, I think, to treat within that population. And there's a lot of very interesting work being done in terms of the role of peers in terms of helping with that and different kinds of navigators. But the message is, yes, you should treat. You need a special team to really keep on them and track them during treatment. They may get reinfected. It's not at a high rate. It needs to be done.
It is on fatty livers for Dr. Rohit. So the first one is we use FibroScan in our practice, and we're going to get the CAP machine soon. So the question is, for patients with NAFO, can we use the CAP score to trend? Is that validated yet? The second question, what's your experience on patients on both pioglitazone and vitamin E? And do you use it for both diabetic and non-diabetic? And what's your experience with it?
Excellent. So there's a paper in January issue of Hepatology where we head-to-head compared CAP with MRI PDFF because we wanted to identify what CAP cut point could be used for a 5% fat on MRI. And the cut point is about 288 dB per minute. And so above 288 dB per minute or 290 is when you have an 80% accuracy that this patient will have a fat fraction of 5% or higher or fatty liver. Now you might be looking for patients who have more fat, say 10%, and then try to get into some sort of a trial. You could use a cut point of 305 decibel per minute. The problem with CAP is it's not extremely quantitative. It's good for saying yes and no at 80% accuracy. But if you are looking for, say, a patient who has 15% fat in the liver versus 50%, CAP is not able to differentiate that difference. But it's able to get you a good deal when you're looking at yes and no for fatty liver. So extreme quantification, not very good. It will be improved. There are new tests coming on ultrasound-based fat quantification on routine ultrasound, such as Siemens or GE, and they'll be coming out in a year or two. In terms of combination of pioglitazone and vitamin E, anecdotally, sometimes I use it. I've used in a patient who had very high ALT and AST, and she was going in for a bone marrow transplant, and they didn't want to give her a bone marrow until the ALT and AST came down. We did a biopsy. She had a NAFLD activity score of 8 out of 8, rip-roaring, steatohepatitis and ballooning. We did some lifestyle changes, and I got her on both pioglitazone and vitamin E. Within 6 weeks, her ALT and AST were, half of where she was 4 weeks ago. Eventually, I took her off of pioglitazone within, 3 months and continued her on vitamin E. She got a bone marrow transplant 6 weeks after starting her medication. So that's where I've used both of the medication. Typically, I'll use pioglitazone in the setting where I have type 2 diabetes. Or at least they have pre-diabetes where I think they might benefit from switching that insulin sensitivity switch from resistant to sensitivity.
Thank you.
Hi there. I have two distinct questions. Rohit, thank you for your talk and for your efforts in tackling this very growing epidemic for us. So we're used to seeing patients in our clinic, middle age, with metabolic risk factors who have NASH. I'm starting to see a lot of patients, so young patients, establishing care with me at age 18 who are having stage 3 fibrosis with NASH. Do you think that the natural history of these, two distinct populations of patients are different? And if they are, Are your research efforts reflecting different studies to address this different population of patients, the older versus the younger patients with NASH and advanced fibrosis?
Yeah, I think you're absolutely right. And one of my hypotheses, even within the families with NASH cirrhosis, is that if you start developing early onset disease, earlier onset disease there could be a potential genetic contribution of rare variants that we haven't identified yet. And they may be working on top of, say, PNPLA3 background. The other possibility is that it could be that on histology, because 1/3 of people have fatty liver, this may be one factor that we think that they all have NASH and NASH cirrhosis, but about 15% of patients have cholestasis, elevated alk-phos, and it could be that there is a pediatric disease or a pediatric genetic variant that causes pediatric disease. We just don't identify it, and they're presenting at a later onset. And that's one of the hypotheses that I'm thinking, because 1 out of 10 families with cirrhosis have no risk alleles related to PNPLA3 or anything known for NASH, and they still have cirrhosis running in their families. So it might be something that is contributing that we haven't yet identified. If you look at pediatric NASH or pediatric liver disease, when you go to, say, Cincinnati Children's, you get a genetic panel done if you present with liver disease. We don't do anything like that in adult disease. The only thing we test is HFE, sometimes alpha-1 antitrypsin, and rarely for Wilson's disease in terms of genetic testing. But I think we may be missing out on many of these diseases that are presenting later on, and those people may be surviving their pediatric onset to a later onset disease. So I think within 3 to 4 years, I expect genetic risk screening within patients with NASH cirrhosis or advanced fibrosis.
Thank you. And my second question is for patients who have functional cure for Hep B, meaning they have loss of surface antigen, undetectable HBV DNA, how long do you follow them with serial blood work, and how long should we follow them still for HCC screening?
So serial blood work, I usually document for a year that the surface antigen is sustained and being persistently lost, and then there's very good data that says really beyond that they're unlikely to sero-revert unless they're immunocompromised. So remember, those individuals are still at risk for reactivation in the context of any form of immunosuppression, right? I think the issue of if and when you can stop doing surveillance is really not well characterized. But in my practice, if I have someone that I've watched lose surface antigen under my watch, I continue doing surveillance as if the surface antigen was still there. We need more data. Right now we have so few that do this that we don't have large cohorts of those surface antigen negative individuals who lost it in their lifetime. So the rules about this will probably change with more effort, but I think you should continue surveillance, and I think that's particularly true if they're older. And I would probably use like anybody over 40. I would continue to do surveillance. The risk is substantially reduced, but it's still there. And now with the coexisting other epidemics of liver disease, fatty liver being the other one, that we sort of see that those individuals acquire new risks as they are aging, I think we want to still be pretty vigilant.
Thank you.
What's the outcome of those immune-tolerant hepatitis B patients who receive antiviral treatment when they were young, early 20s? Do we keep on treating them because their viral load would never be totally suppressed?
Yeah, so that's the other piece of it I didn't get into, but it's actually, there have been trials done where they have taken the 20-year-olds that are immune tolerant and treated them. The goals of those therapies, generally they're looking at 1 or 2 year outcomes. And those studies show that at the end of 1 to 2 years, only about 75% of them are suppressed. So, they take a long time to suppress, and in my hands, sometimes you need more than one drug. It's very hard to get them suppressed, so that's the first thing. And the other thing is they don't lose the antigen, and they're not losing surface antigen for sure. So the question is kind of what is our endpoint here? So if you put those individuals on treatment, then you have to be prepared to treat them long term. And nobody really knows over decades how many of them will lose surface antigen because nobody's done that study. But there are a few patients where I have to treat them, and the most common scenario for us is the people that are in medical practice, right? So you have to, if you have somebody who's immune tolerant and they're in a surgical program, you have got to suppress those individuals. It's a requirement. So I have immune tolerant patients that I've put on treatment, but I've done it with because they're in settings where you have to worry about them transmitting to others and where you're required to get their viral load to low levels. So in that setting, I have treated. But you can tell my bias is generally the 20-year-old should not be treated. Because I don't think we have good treatments. I don't think they're very effective. We don't know what the end point is. And now with all these new therapies coming, I'd say wait for the better drugs to come so that we can get more effective loss of surface antigen.
So a question on surveillance, I just don't know if there's any information on this. So our primaries order hepatitis B panels, and invariably it's got the antigen, the antibody, and the core. So sometimes the antibody and the antigen come back negative, the core is positive. Sometimes they'll send the DNA and the DNA is positive. So they have occult Hep B. So then the question becomes, do you survey these patients? And for those that they don't send the DNA, but they ask you that they're core positive, do you then send the DNA and say, well, they have occult Hep B, they should be on surveillance? Okay, so it's probably the most challenging area, and you're right, we have very little data. But when somebody is core positive only, there's first of all, there's a possibility it's a false positive. So that's why the guidance now says we don't recommend actually testing for core now. We recommend testing for surface antigen and antibody, and if the antibody's negative, vaccinate, because we're trying to maximize the protection and vaccinate. But these are part of panels, so the core comes back. So it depends on who you test, but young individuals, women, people with autoimmune conditions can get false positive antibodies. So the first thing is, I would say vaccinate, no harm, because you would maybe want to protect that group that it's a false positive. Among Asian Americans or those in which there's high endemic rates of HBV, a core positive generally is real. It's somebody who's been exposed and has cleared. The thing that we don't know, of course, when you pick them up, is did they clear early in life, like very early? Maybe they were exposed and lost their surface antigen before the age of 20. That individual probably is not at risk for at least cancer and other things that we worry about. On the other hand, if you're seeing them at the age of 60 and they're core positive, they might have just lost their surface antigen last year and may have had 50 years of disease. So it's 60 years of disease. So it's very hard to interpret the core only. What I do in my practice is if somebody is from an area where they were likely exposed as a young child or as a baby, so endemic areas, I actually try to figure out if they've got any evidence to suggest liver disease. So we now have FibroScan, so I actually have to say I use that actually in these core positives where I'm worried that maybe they have had their disease a long time and I'm picking them up late. So I actually use that as a way in the sort of 50 and older group to decide if I'm worried about that patient or not. But do you send the DNA?
I don't do it routinely.
No.
I think the group in which you would do it are patients in which, sort of the group in which it's been shown as HIV-infected patients, you should send it in that group, or anybody who's on immunosuppressive therapy, I think you should do it in that setting, because that's where we really have seen that occult persistent HBV DNA that may warrant a specific treatment. But I do not do it routinely in every core positive patient.
So I have one last question I'm going to ask Gina, and this I think comes up in many practices, and that is the use of non-selective beta blockers in patients with more advanced liver disease, but especially in the patients who have had bleeds before. They're on them, they're progressing, maybe they're on the transplant list, and do you stop them, continue them? Your thoughts on them?
So this is a pretty controversial question. I think that the traditional teaching is that, yes, these patients should be on beta blockers for secondary prophylaxis. However, newer data from Dr. Runyon actually was saying that if they have refractory ascites, if they're severely deconditioned, you should consider them not being on it. I think, like any treatment, you have to follow these patients, right? And you have to use your common sense. So if they're at the very end stage of portal hypertension, their systolic blood pressure is 90/50, they're on midodrine, I would stop the beta blocker, right? Because you're kind of going towards two different things there. I think that it's tricky to start them in-house because oftentimes we'll see these patients as in-house consults. So I think that it's really in the outpatient setting that you should be determining whether these patients should be on these medications. And I think if they are, hypotensive, bleeding, et cetera, I would stop it and consider starting them as an outpatient. But I think that ultimately there is a benefit to beta blockers in these situations. There was an abstract at EASL I didn't talk about where, again, we're trying to find that sweet spot. Who are the patients that would benefit from these treatments? And there was an abstract there that said that rather than MAPs, you shouldn't even consider using systolic blood pressure as your guiding light.
Oh, yeah, please.
Sorry. So a 62-year-old Asian American born vertical transmission, immune tolerant to Hep B. His brother lives in Japan. He's about 2 years older. He's never been treated. He's never had HCC. This gentleman has perfectly normal LFTs, like 16, 17 AST/ALT. I biopsied him twice, 15 years apart. Comes back as normal liver, completely normal. Would you treat him?
I think we might have the same patient. I have one like that as well. And I haven't treated him yet, actually. I have a couple of patients that are, I would say, over the age of 50, actually. But I have biopsied them to I'm looking for a reason to treat them. I really am. But they have nothing. And in a negative family history, I'm still okay with not treating them.
I see these abstract age 30, 40,
Correct.
I start feeling guilty.
No, but you are doing the right thing. I think you should look for a reason to treat. So sometimes when they're just transitioning, viral load's coming down a bit, liver enzymes starting to creep up, like more in the 30 to 40 range. I think that's for me the trigger to treat, or I do a biopsy, and if it's showing any kind of inflammation, done. They're on treatment.
I think the key thing here, as Norah pointed out, is family history. If that same patient had a family history of HCC, then the cumulative risk over lifetime is 60 to 80% for hepatocellular carcinoma.
Sure, yeah. Thank you.
Actually, I have one last question, and that's for Rohit. So I'm wondering, with the treatments for NASH that are coming out, are these people now going to do great from their liver disease but die of cardiovascular disease, and will these medications maybe have a positive effect? Will we be not recommending bariatric surgery and weight loss and more just treating them with drugs, and could they actually be harmed?
I think we all want to make sure that we help our patients holistically and not just treat their liver and then put them harm's way for cardiovascular disease or cancer. So I do think that the good sense is going to prevail, and people would be looking for overall improvements. In fact, there might be even push where for phase 4 programs that we might include cardiovascular risk and cardiovascular mortality to help, not to ding a drug, but to really show benefits with certain drugs. So I think as we go towards FGF21s, thyroid hormone beta receptor agonists, and then GLP-1, and then PPAR alpha, PPAR alpha delta, there you might start seeing benefits with CVD risk reduction, at least with LDL cholesterol, weight loss. And there would be therapies where we would actually improve both liver disease as well as CVD risk. Another thing, Jeff, we are trying to sort out is when I see a patient today, can I quantify what is this patient's high risk over the next 5 to 10 years? Is it CVD or liver disease or cancer? And if we can then mitigate that risk first.
Thank you. All right, I guess that wraps things up. I just want to thank our panel and our speakers. They were great. And please.